Dear colleagues, my name is Carlos Lifchitz, and I want to thank Professor Mortada and the organizing team for another invitation to participate in this meeting. This time, of course, as I said before, in a virtual form, and I missed the opportunity of interacting with all of you and the beauties of Hurghada and delicious Egyptian food, but that's what we have today. The topic this afternoon is that of abdominal pain. And with that, I would like to start my talk. As you have said, you read before, I'm a former associate professor of Baylor College of Medicine in Houston, Texas, associate physician in gastroenterology, hepatology, and transplantation at the Italian Hospital in Buenos Aires, Argentina. As you probably know, and depicted in this beautiful Turkish drawing from the 19th century, the brain is connected to the intestine, and this is depicted like a forest or with a stream. And indeed, we know very well how much people who were nervous or were upset would sometimes get diarrhea. And we know now as well from the knowledge of the intestinal microbiota that the intestine can also modulate the brain. So it's a two-directional thing. And the reason I'm presenting this now is because through the talk you will see that indeed there is a lot of difficulty making the diagnosis of abdominal pain, whether it's originated in this area and we perceive it here, or it's originated in this area and is sort of reflected in the intestine. Most of what I'm going to say this afternoon is based on the Childhood Functional Gastrointestinal Disorders on Child and Adolescent that was published a few years ago in Gastroenterology and follows the Roma 4 criteria. Throughout this presentation, you will see that these things are highlighted because they are the same in everyone, and I will not repeat, which after appropriate evaluation, the symptoms of all of each of the entities cannot be fully explained by any other medical condition, and the criteria is fulfilled for at least 2 months before the diagnosis. This, of course, presents a problem in clinical practice because you cannot tell a parent or a child to wait another month or so before you make the diagnosis. But the first one to discuss is functional dyspepsia. Dyspepsia includes one or more of the following bothersome symptoms that occur at least 4 days every month. Postprandial fullness, early satiety, that is, the child early on after starting the meal says that they are full and don't want to continue eating, and epigastric pain or burning, which is not associated with defecation. There are 2 subtypes of this form, which is the one that I just described, very similar to that is the bothersome postprandial fullness and early satiety. Supporting features of this include the bloating in the upper abdomen, nausea, and excessive belching, burping. Here we have a child who says that he cannot complete his meal because he feels full. And this, although it might look a joke, many times in clinic we see this type of situation. The other subtype is the epigastric pain syndrome, which includes the bothersome, severe enough to interfere with normal activities of pain or burning localized to the epigastrium, and the pain is not generalized or localized to any other part of the abdomen or chest regions, and is not relieved by defecation or passage of flatus. Supportive criteria for this include burning quality of the pain, but without retrosternal component that would make more for a gastroesophageal reflux disease. And the pain commonly is induced or relieved by ingestion of a meal, which may occur while fasting. The pain. We then move on to another category, which is that of irritable bowel syndrome, where the abdominal pain must last at least 4 days per month. They have to have this symptoms related to defecation or a change in frequency of stool or a change in the form, the appearance of stool. That is, they normally go from being constipated to an episode of loose stools or vice versa. In children with constipation, the pain, however, does not resolve with resolution of the constipation, because if they did not have irritable bowel, it would be classified as functional constipation. The symptoms that together also support the diagnosis of irritable bowel syndrome include abnormal stool frequency, and for research purposes only, we consider abnormal as defined as more than 3 bowel movements or less than 3 bowel movements per week. And abnormal stool form, lumpy, hard, or loose, watery stool, abnormal stool passage with straining, urgency, or feeling of incomplete evacuation. Passage of mucus might be seen as well, just like we see in chronic non-specific diarrhea in the first year of life, and bloating of feeling of abdominal distension. As you have some menus, you might be familiar with another menu, which is the Boston stool chart. And this in older children is very simple, because you show them this and they will let you know which category their stool looks like, or their parents will, and that will allow you then to put it in your notes and compare after treatment. The differential diagnosis of irritable bowel syndrome, if it is diarrhea predominant, it is of course infection, celiac disease, lactose malabsorption, excess fructose or sorbitol intake, this is usually fruit juices, inflammatory bowel disease, or drug induced. On the other hand, if it is constipation predominant, it could be chronic stool withholding, hypothyroidism, Hirschsprung's or other types of intestinal mechanical obstruction, or chronic intestinal pseudo-obstruction. A very unusual but very dramatic problem of abdominal pain is that of migraine. Abdominal migraine, I have to say that many people diagnose it very frequently. I, in my career, have seen it very rarely, but I've seen it a few times. And it's a paroxysmal episodes of intense, acute periumbilical, midline, or diffuse abdominal pain, which lasts 1 hour or more. And the pain should be the most distressing symptom of all of them. The symptoms can occur between weeks or months. The pain is truly incapacitating and interferes with normal activities. And it is typical, each patient has its own stereotypical pattern. It might be associated with 2 or more of the following: anorexia, nausea, vomiting, headache, photophobia, and pallor or pallor. The differential diagnosis of abdominal migraine includes malrotation, which of course can be diagnosed with an upper GI contrasted X-ray, biliary tract disease, and ultrasound will help in that regard, intussusception with a lead point, uteropelvic junction obstruction, Crohn's disease, unrecognized constipation, pancreatitis, and acute intermittent porphyria. And I think that unrecognized constipation is something to keep in mind, because I have seen many, many patients that come in with this type of symptomatology. Either they have severe abdominal pain that is incapacitating, sometimes it's throughout the colonic frame, or it could be just in the right lower quadrant or in the upper rectum area. And they tell you that the pain usually starts after they start eating. And many times the parents will tell you that the child runs to the bathroom and has diarrhea. This is typical of a child with unrecognized constipation. And that's one of the only indications in which I do order a gastrointestinal X-ray, a plain X-ray, to see if the child is full of feces. And normally I look at the X-ray myself, because the radiologists, particularly if they are adult radiologists, are usually not impressed by the amount of stools. that a child might contain. But this is the simplest diagnosis to make, the fastest treatment, and the parents cannot believe that just with a little bit of polyethylene glycol, this child's problems are resolved. Functional abdominal pain, again, 4 times per month, include all or some of the following. Episodes of continuous abdominal pain that does not go solely during physiological events, such as and it's not associated with eating or with menses. Insufficient criteria for irritable bowel, functional dyspepsia, or abdominal migraine. The differential diagnosis again includes constipation, parasitic infection, lactose intolerance, excess fructose or sorbitol intake, such as with apple juice, non-steroidal anti-inflammatory agents, Crohn's disease, and eosinophilic gastroenteritis, of which I will speak in a minute. The functional abdominal bloating particularly is seen in pre-adolescent girls or teenage girls, which they feel full bloating with visible abdominal distension, and there's not enough criteria for a diagnosis of dyspepsia, irritable bowel syndrome, or functional GI disorder. This is the situation of the child. Respected to the bloating and the gas, some countries are very organized in regards to this. And this, I was in Denmark. Denmark is a very well organized country where they have a plan. And actually the plan is different for summer and winter. And from May 15th until September 15th, so it just changed recently, from Monday to Saturday, it's from 11 to 5 p.m. and on Sunday it's a different stuff. But what I have to show you that this is the plan. So again, one has to have a plan with these patients and try to get them organized with their symptoms. Eosinophilic gastroenteritis or colitis is an entity that has appeared in the spectrum in the last 15-20 years. It is characterized by crampy abdominal pain, nausea, vomiting, diarrhea, sometimes even bleeding, and weight loss. The pain is very characteristically well localized, and many of these children present with right lower quadrant pain, which makes it think that could be an appendicitis. I have seen many children like this, particularly when I was in Houston, not so much in Argentina, but they precisely say that the point of pain is in the right lower quadrant. These children, they continue to go to school, and sometimes their activities are interrupted. They could be on a weekend playing outside or watching TV or doing one of their video games, and all of a sudden they start the pain. This is totally different than the child with irritable bowel syndrome or functional abdominal pain, who normally does not have pain on weekends or during vacation or when they are doing activities that are not stressful. 50% of these children might have peripheral eosinophilia, leading to eosinophilic infiltrates in the stomach and intestine. When you do, some of them have prior history of atrophy, but not all of them. And when you do an endoscopy, if this is the normal stomach, the child with gastroesophageal gastroenteritis, because this is different than the esophageal eosinophilic disease. You can see all these are eosinophilic abscesses which alter intestinal motility. They have delayed gastric emptying. They feel full for many hours, and then have, again, as I mentioned, they have the localized abdominal pain. Many of these patients have a recurrent course, and they will not improve. And some of them will improve with diet and eliminating all potential allergens. So what is the model thinking about irritable bowel syndrome? What is thought? This is an old cartoon, but it has not changed essentially. So there are early life genetic and environmental factors that might affect the physiology and also psychosocial factors. So what are those? For example, in the studies in adults, twins, the proportion with co-twins of irritable bowel syndrome, if they are dizygotic it's 9%, but if they are monozygotic, it's 14%. If the mother has irritable bowel syndrome, it is likely that children, if they are monozygotic twins, 17% will be affected. So there is something in the genetic component that might be causing this syndrome. But there also are other aspects. For example, this is represented here, the number of GI clinic visits of children depending on their parents. So if the parents, mother or father, have very low complaints of gastrointestinal problems, the children go very rarely. But if the parents have irritable bowel syndrome, it is very likely that their children will be visiting the GI clinic much more often. There is also the theory of neonatal stress. Studies have been done mainly in animals where rat pups in the postnatal days between 2 and 14 either were handled or had a maternal separation for 100 minutes, 180 minutes per day. This is in the graph called MS, so maternal separation 180 minutes, or not handled or separated, not handled. And at 2 months of age, they did electromyographic recordings to evaluate for stress. So what they did is they stressed the animals and they did recordings of the electromyographic activity. And as you can see here, the amplitude of the waves of the distress measured was much higher if the animals had been separated from their mothers when they were pups, as opposed to the pups that at 2 months of age who had not been separated. Therefore, this indicates that neonatal stress could predispose, at least in these animals, to further abdominal pain. So life stress, psychological states, capacity to cope, and social support will also have an interaction with the central nervous system, affect physiology, motility, sensation, and then leads to symptoms of irritable bowel syndrome. Psychosocial factors include the family history, as I just mentioned, family distress, the fact that many parents see their child as disabled and find something to occupy themselves, and the child becomes like the whole thing of their lives. So taking the child to the doctor, victimizing the child, etc. The more disabled, the more it leads to healthcare seeking. When you tell the parents that the child is healthy, they get upset with you, they change doctors, and the mom somatization interacts with child somatization associated with increased referrals to tertiary care. Then there's a related factor also about the sensation, how different people feel and react to distress and pain. So there might be changes in motility and visceral hypersensitivity. Patients exhibit more symptoms during transit of a standard meal and gases versus normal subjects. There might be greater sensitivity to gut distension at levels causing no change in motility. The pain can be distributed to the upper intestine, to the back, and even to the thigh. And there are changes that are specific to visceral stimulation. In this study, for example, what we see is that normal volunteers and patients with irritable bowel syndrome, they had a rectal balloon put and it was inflated. And what you can see that normal individuals only report pain when the percent of people reporting pain is very low. However, when you have irritable bowel syndrome, the percentage of individuals with irritable bowel syndrome that report pain with the same volume distension of these rectosigmoid balloons is much greater. So there is a visceral hypersensitivity and lower tolerance of pain threshold. In Carlo Di Lorenzo, already quite a number of years ago, compared visceral hyperalgesia in children with abdominal pain, 10 with functional abdominal pain and 10 with irritable bowel syndrome. and they put a gastric barostat, so they put a balloon in the stomach, and they were admitted for colonoscopy for treatment of fecal impaction, and they had no history of abdominal pain. These were the controls. And then there were 7 asymptomatic patients that were recruited for rectal barostat. So they put a balloon in the rectum of these children and dilated. And you can see that the pain score, it was significantly higher in rectal distension and gastric distension for patients with irritable bowel syndrome, recurrent abdominal pain compared to controls. So, and you can see here in the with the pressures, the dilatation of the balloons in the rectum are still relatively small, that the majority of normal individuals of control don't even complain. Well, look at the levels of children with irritable bowel syndrome and recurrent abdominal pain. And that's true for gastric distension. So there's a role for the central nervous system. Patients have different pattern of cerebral response to pain versus controls as well. There's an increased activation of the anterior cingulate cortex, which I will abbreviate ACC. They respond to emotionally laden ideas, memory, and stimuli, and you can actually visualize in appropriate studies in the brain how just saying words or giving the patients to think about something is reflected in the brain in a different way where they have abdominal pain or they are controlled. And they also have an impaired activation of pain inhibiting circuits. So here we see response to colorectal distension by a balloon in a control with very little activation of the brain. Compared to an individual with irritable bowel syndrome, you can see all the areas of activation in the brain just from the distension of the rectum. So definitely the sensitivity of these individuals is different. And finally, I want to mention something that occurs after infection. A child who comes in with abdominal pain and sometimes persistent diarrhea, or sometimes alternation of diarrhea and constipation. And when you ask a questionnaire, detailed questionnaire, perhaps 2 months before they had an episode of acute gastroenteritis. And this is not an unusual finding, and it's important to keep in mind because post-infection irritable bowel syndrome, it begins after an enteric infection, perhaps in 30% of cases, whether it could be bacteria or parasite. If you biopsy these patients that had increased lymphocytes and enteroendocrine cells in the intestinal biopsies, the psychological profile pre-illness might be predictive that this was going to happen. It is not known if it is a genetic predisposition or whether it falls in the spectrum of irritable bowel symptoms. So then there is the symptom and experience and behavior. So what does a child do with these symptoms? As I mentioned before, the parents usually, the child who's in school tells the teacher sends the child to the nurse calls the parents, the child is picked up from school, they go home, at home they feel better. Then they are, when they go back to school after several days, they are behind in their homework. So children tease them, they are bullied, and this, instead of improving, it worsens the situation. That's why it's very important that these children persist in going to their normal activities. So the evaluation has to be a diagnosis of inclusion. That doesn't mean that one has to do all possible tests, but really think about what may be going on and compare this to other patients and say, well, I'm not going to do this because of this, or yes, I'm going to do it because of this reason. So the functional abdominal pain generally can be diagnosed correctly by the primary care in children 4 to 18 years of age if there are no alarm symptoms or no normal physical examination. And yes, it's important to do a stool sample for occult negative blood. The alarm symptoms or signs generally are an indication to pursue specific diagnostic testing, such as anatomic, infectious, inflammatory, or even metabolic, like hypothyroidism. Testing may also be performed in very rare occasions to reassure the patient. But I always say you know, if the patient comes with come to pediatric gastroenterology and said, oh, my child already had all this done. So I said, okay, we will do this next one. So every doctor adds one more test, and when you're done with all the available tests, you start all over from the beginning because, you know, 6 months have elapsed. That's not the right way to address these patients. And one has to evaluate and treat in the context of the biopsychosocial model. If you are not convinced that the child does have a functional pain, it's going to be very difficult to convince the parents. And yes, you could be wrong, and one is wrong sometimes, but you establish a relationship with the patient and tells them, well, if you feel that this is not working, come back in 15 days, in 1 month, etc. Or if any of these alarming signs appear. The potential alarm features in children with abdominal pain are family history of inflammatory bowel disease, persistent localized pain like right upper quadrant or right lower quadrant, dysphagia, adenophagia, persistent vomiting, gastrointestinal blood loss. This is always something, unless the child has a fissure from constipation, nocturnal diarrhea, the child wakes up and has diarrhea, arthritis, perirectal disease, which that's why it's very important always to do a physical examination and look at the perianal area. Involuntary weight loss, deceleration of linear growth, delayed puberty, or unexplained fever. In that case, it's justified to do a complete blood count, sedimentation rate, C-reactive protein, liver panel, amylase, and lipase, stool studies for giardia, several guaiac stools for occult blood, Clostridium difficile if the child has diarrhea, and it may be necessary to do some contrast studies, either upper GI or an ultrasound or a CT scan in certain cases, and upper and lower GI endoscopy and biopsy. What about the treatment? Well, the treatment usually is non-pharmacological, and you explain to the child and parents the condition, use pictures, use simple language, you explain the physiology of brain-gut interaction, the visceral hypersensitivity, the chronic but non-threatening usually resolves. And I always tell them, because sometimes the parent says, he's been having or she's been having pain for 3 years. And I say, well, you know, the fact that they look so well, despite of having had this problem for 3 years, it's indicative that this problem is not a bad disease, but probably a functional disease. You can do cognitive behavior therapy, relaxation, distraction, keep moving. Don't over reassure, because sometimes we are wrong. And indeed, we might be, the child might present with something and then it turns out that it has Crohn's disease or has some other thing. What about diet? Well, this is quite controversial. There are multiple studies with the FODMAPs. They seem to be good, and why not try them? You have to eliminate gas-producing foods, fermentable oligosaccharides, disaccharides, monosaccharides, and polyoligosaccharides. But the list of things to eliminate is extremely large. It's pears and apples and wheat and onions, raw onions, and sweeteners, and apple juice, and raisins. You can do grapes and cabbage. So cauliflower, Brussels sprouts, all the fruits that have a big pit, all these beans. So it's not an easy thing. This is a systematic review that was published more recently in the Italian Journal of Pediatrics, and they did a survey of the effectiveness of FODMAP-restricted diets. And they saw that in this review that it was good in 12 of 13 intervention trials. So that's pretty good. But there's only one study in children, that by Chumpitasi, that shows that indeed there was an improvement. There was no effect found when a lactose-free diet was introduced, but yes, a fructose-restricted diet was effective in 3 or 4 studies. And that again is eliminating all the fruit juices that have a greater amount of fructose than glucose, such as apple juice and white grape juice. There are a series of medications that we're not going to discuss, the antispasmodics. Many of the antispasmodics lead to constipation, so the child might then become constipated in addition to the problems. There are no studies, or not many studies with probiotics showing effect, and there are some studies using complexity of probiotics that have shown that indeed there might be a improvement in irritable bowel syndrome or functional abdominal pain. It's a study from Chicago in the United States. Well, so now it's my time to say goodbye. This is the obelisk in the central part of Buenos Aires, one evening with lots of illumination and a couple dancing tango. And with that, thank you very much. Shukran.
It's once more a great pleasure and honor to give a lecture at this conference. I would like to thank the organizers for inviting me, especially my friend during many years, Dr. Mortada. Here's the title of this lecture: Acetaminophen in the perinatal period, potential long-term adverse effects. And I will give you some of the background why I have chosen this topic. Acetaminophen is has a trade mark name of Tylenol or paracetamol. I don't know what is the name in your country. Let's see now. Here it goes. So I'll start out with the background, why I think this is an interesting topic. So in the 1980s, acetaminophen replaced acetyl salicylic acid as an analgesic and antipyretic drug, especially in young children. And the reason for that was that acetyl salicylic acid had been linked to Reye syndrome. I was a very young pediatric resident at that time. I'd just been a few months in pediatrics, and I remember that almost from one day to the other, we replaced acetyl salicylic acid with acetaminophen for these children. Now, from the 1970s, there's been a sharp increase in autism in US. It's been more than a 20-fold increase in prevalence. And this epidemic took off in the late 1980s at the same time as acetyl salicylic acid was replaced by acetaminophen. And the so-called late onset of autism skyrocketed. There are two types. We have the birth type autism, and it also increased, but not as much as the late onset. So in 2002, Pangborn concluded that most autistic cases were acquired, caused by a factor, or maybe several factors, which were not present 20 years earlier. And he and others have suggested a number of risk factors. So in 2008, Schultz and coworkers, they made a survey, and they demonstrate that acetaminophen, but not ibuprofen, used after measles, mumps, rubella, MMR vaccination, which is typically taken around 12 to 15 months of age. It was significantly associated with autistic disorder in children less than 5 years. There was no link between autism and the vaccine. No link between autism and the vaccine has later been verified, and I think it's important to underline that. Now, in 2016 and 17, two studies came out from Scandinavia. The first one from Denmark, where they were able to show that prenatal use of acetaminophen accompanied was accompanied with autistic spectrum disorders with hyperkinetic symptoms. And then the year after, a Norwegian study came out showing that maternal use of acetaminophen more than 29 days during pregnancy is associated with attention deficit hyperreactivity disorder, and the hazard rate was 2.2 with confidence intervals 1.5 to 3.24. So here we can see how autism diagnosis has exploded in the US from the 1970s. The bottom part of the curve here, you see here, it takes off around 1980, and around 1990 it really skyrockets, as you can see here. In the upper panel here, you see that autism with symptoms shortly after birth, yes, it has increased, but not as much as the more late onset autism. So this also indicates there must be some external factors which are responsible for this increase. Only a couple of years ago, Masarba and co-workers published a systematic review and meta-analysis. They included more than 130,000 mother-child pairs from 7 studies, and they had quite a long follow-up, at least 3 to 11 years. And here you see the risk of attention deficit hyperactivity disorder, ADHD, after acetaminophen exposure during pregnancy. Relative risk, 1.34 with confidence intervals 121 to 147. So it's a 30% increased risk if the mother has been exposed to acetaminophen during pregnancy. And similar results were found regarding autistic spectrum disorder, ASD. Relative risk 1.19. This is also, as you can see here, significant. And for hyperactivity symptoms, yes, relative risk 1.24 and also significant. And also for so-called conduct disorders, there is an increased risk after exposure to acetaminophen in pregnancy. However, all these studies I mentioned so far, they were observational. They are based on retrospective questionnaires, and as you all know, this leads to a risk of so-called recall bias. So therefore, it was important when G and coworkers last year published a prospective study in which umbilical cord acetaminophen and some of its metabolites were measured. So here you can see the distribution of cord plasma acetaminophen. Here is the unchained acetaminophen A here, and the B panel is some of the metabolites. And you see that there are different curves according to different diagnoses. It's difficult to read this here, but you see that there is different patterns here. But what is most important is, of course, the clinical findings. So what they did in this study, they compared the outcome in children related to how much acetaminophen or metabolites of acetaminophen they could detect in the umbilical cord. So they compared the first tertile with the second tertile or the third tertile. So if you look here first and concentrate on the third tertile here, so for attention deficit hyperreactivity disorders, odds ratio for developing ADHD is 2.88, confidence intervals from 1.80 to 4.66. For autistic spectrum disorders, odds rate is 3.72. For ADHD and autistic spectrum disorders, odds rate is 3.38, so-called developmental disabilities here, DD, you see that odds ratio is only 0.86. It's not significant. And they found the same pattern when they looked at all the metabolites combined. So in order to make it easier for you to read this, I took out the most important results of this study, in my opinion. So they compared acetaminophen in umbilical cord, the first versus the third tertile, and attention deficit hyperactivity disorder, odds ratio 2.88, almost a threefold increase. Autism spectrum disorder, 3.72, almost a fourfold increase. The combination of these two, 3.38, but developmental disabilities, no effect by acetaminophen. So for that reason, when I read this, I became concerned. We use acetaminophen a lot, not only in pregnancy. We give it to newborn babies. We give it to preterm babies. We even treat patent ductus arteriosus by giving acetaminophen. Maybe we should be more careful, was my idea. So I wrote a commentary for neonatology, where I summarized some of the background I have mentioned to you, and also the result of the G study. And I asked if it's reason to ask for caution of prenatal and postnatal acetaminophen administration. It's not known if there is a special window where the developing brain is more vulnerable to acetaminophen and its metabolites than later in life. So I suggested that until more data are available, care must be exercised before this potentially toxic substance is given to individuals with developing brains. And all studies, including acetaminophen in newborns and infants, should, as suggested by Olson and Shah, include a proper follow-up for potential long-term adverse effects. So what did Olson and Shah state in their Cochrane review published 2 years ago? Well, they didn't find any difference in neurodevelopmental outcome in children exposed to paracetamol, acetaminophen, compared to ibuprofen. However, due to the low quality of evidence and due to concerns raised regarding neurodevelopmental outcomes following both prenatal and postnatal exposure to paracetamol, these authors asked for long-term follow-up to at least 18 to 24 months postnatal age in any studies of paracetamol in the newborn population. So, as a response to my commentary, these two guys, Van den Anker and Allegaert, wrote a response to my commentary. And who are these guys? John Van den Anker is probably the leading pediatric pharmacologist, at least neonatal pharmacologist in the world, and Allegaert also from Belgium is also. So these two guys are really experts in this field. So of course I became a little bit concerned when I read their response to my commentary, and this is what they wrote, which I think is makes sense also. The question is, of course, if just measuring acetaminophen and its metabolites in cord blood and linking to autism spectrum disease or attention deficit hyperactivity disorders will help us explain the mechanisms behind these findings. Is it the higher exposure to acetaminophen and its metabolites that causes ASD, ADHD, or is it the fact that you're going to develop ASD, ADHD? The reason why you have a different clearance of acetaminophen. There is some evidence that supports the fact that kids with ASD, ADHD indeed have a different metabolism of acetaminophen, and perhaps as a consequence have an elevated risk of adverse event if exposed to acetaminophen. So they concluded that at this moment, there is no reason to discontinue the use of acetaminophen in pregnant women and their neonates, because the alternative, the use of opioids, has proven to result in a dramatic increase in opioid-addicted neonates across many countries worldwide, while exposure to other non-steroidal anti-inflammatory drugs like ibuprofen or indomethacin is associated with a much higher risk for fetal ductal closure when compared to acetaminophen. So what should I say when these two big authorities conclude that? However, very recently, just a week ago, I came across this new publication by Baker and co-workers published in JAMA Pediatrics, Association of Prenatal Acetaminophen Exposure Measured in Meconium with Risk of Attention Deficit Hyperactivity Disorder mediated by frontoparietal network brain connectivity. So what I did in this study, they included 345 newborn children, and they measured acetaminophen in meconium, and they detected acetaminophen in 57.7% of the cases, and they found attention deficit hyperreactivity disorder in 9.6% of the babies, approximately 10%. However, compared with no acetaminophen, detection of acetaminophen in meconium was associated with increased odds of attention deficit hyperreactivity disorder, odds ratio 2.43, very similar to what others have found now, and also the yeast study. And they also found that there's a dose response association, so that each doubling of exposure increased the odds of ADHD by 10%. Children with acetaminophen detected in the meconium showed increased negative connectivity between the frontoparietal, parietal, and default mode network nodes to clusters in the sensory motor cortices, which mediated an indirect effect on increased child hyperreactivity. So this is what they found, which I just have summarized now, that if you have acetaminophen detected in the meconium, there's an odds ratio of 2.43 risk for attention deficit hyperactivity disorder to develop, as shown here. And here we see that there is a significant difference in so-called connectivity in children exposed versus not exposed to prenatal acetaminophen. So those who had been exposed had a much lower connectivity, and we know that this is associated with hyperactivity. So those who have hyperactivity above the median has a lower connectivity than those who are below the median. So of course these are very interesting results. So the conclusion of this study was that, together with a multitude of other cohort studies showing adverse neurodevelopment associated with prenatal acetaminophen exposure, this work suggests caution should be used in administering acetaminophen during pregnancy. Research into alternative pain management strategies for pregnant women could be beneficial. So at the end, why should acetaminophen be toxic? Well, if you look at the metabolism of acetaminophen, it goes through two pathways. Most acetaminophen is most of the acetaminophen, which is metabolized in the liver, is sulfated to this non-toxic metabolite, but 5 to 10% goes through this very toxic metabolite here. And in order to detoxify this toxic metabolite, NAPQI, you need glutathione. We know that especially preterm infants are very low in glutathione. So probably more acetaminophen is metabolized by this very toxic metabolite here. So that could be one reason that we should be careful with acetaminophen, especially in preterm infants. And it also inhibits prostaglandin synthesis, and prostaglandin D2 is important for brain development and function, and prostaglandin E2 is important for firing rate of neurons in the hypothalamus and may play a role in resolution of inflammation. So there are some theoretical reasons why acetaminophen could be detrimental also, especially in the newborn and preterm baby. So we know that autism, risk factors of autism, a number of risk factors, but inflammation and oxidative stress are among risk factors for development of autism. And so here is listed, this is from Parker and coworkers, some of the risk factors, inflammatory risk factors, showing here, for instance, chronic psychological stress, vitamin D deficiency, inflammatory diets, sedentary lifestyle, increased age of parents at time of birth, autoimmune conditions, obesity, diabetes. And then risk factors of oxidative stress, preterm birth, for instance, male gender maybe, and also other risk factors as infections, heavy metals, organophosphates, cigarette smoke, and air pollution, etc., etc. So these, then acetaminophen could add to these risk factors, both before birth and after birth, and maybe contribute to triggering of autism. So this was just a brief summary of this topic. Is it still reason to be concerned to give acetaminophen to the developing baby, to the developing brain? I think that we need more studies, but I think we should be aware of that. And I think we need more prospective follow-up studies in this field. So thank you so much for your attention, and I'm happy to try to answer any questions from the audience. Thank you so much.